هو الحقيقة مش argument، يعني هو أنا هاخد الكلام من دينا إن الموضوع هيبقى فعلا individualized، ويمكن أنا هتكلم أكتر على how to choose the patient. As you all know, GIA is the most common rheumatologic condition of childhood. It is considered to be the most common systemic cause of childhood uveitis. Cataracts is by far the most common ocular complication of GIA. Risk factors for cataract development as well as for the development of uveitis in GIA are in the form of the oligoarticular GIA, the age of the patient less than 7 years, the seronegative polyarthritis form of GIA, the ANA positivity, duration of uveitis less than 4 years, as well as the degree of inflammatory control and the daily use of topical corticosteroids. All of these are risk factors for the development of cataract and the intraocular uveitis. As Dina said, cataract surgery in GIA children has got the worst visual outcomes with a more complicated post-surgical course. Cataract surgery may be challenging, again, for the limited surgical exposure due to the posterior synechia, the fibrinous membrane formation on the lens capsule, the pancreatopathy, and the technique, as Dina said, it's usually in the form of synecholysis, removal of any membranes on the anterior lens capsule. The capsule is over. We usually use the stain. The capsular access may be difficult at the time of the approach, with changing the texture of the capsule. Again, we should do a full irrigation aspiration of the lens matter in order to decrease the load of post-operative inflammation. For these patients, we do, especially at a young age, we do posterior capsular access or posterior capsulotomy with anterior vitrectomy, and offshore by the end of the surgery, we may inject intravitreal injection of triamcinolone, a subconjunctival injection of corticosteroid in order to decrease the post-operative complications that we may meet. حقيقة published data كلها recommend perioperative and post-operative control of ocular inflammation by immunotherapy before doing the cataract surgery, with uveitis should be quiescent typically for at least 3 months prior to surgery. A complex decision regarding IOL implantation الحقيقة معلهوش strong consensus لغاية دلوقتي, where we should consider كمان the comorbid ophthalmic pathologists while doing our surgery and taking the decision. Although recent studies demonstrated favorable overall outcomes, still primary implantation is a controversy because of the rate of the synechia formation, the perimembrane formation, hypotony, secondary cataract, and the possibility for the IOL implantation. Different studies demonstrated that the number of secondary procedures was more common in the pseudophakic eyes when compared with the aphakic eyes in GIA cases. The primary IOL implantation with increased prevalence of visual axis ossifications when compared to the cases that left aphakic. Again, with the key for success is the maximum control of the perioperative inflammation and the intensive follow-up. IOL implantation should be obtained in well-selected eyes in order to decrease the risk of inflammations as well as the better visual results. This is one of the cases from the CUPS registry files. This is a 6-year-old female patient diagnosed as GIA, presented with bilateral cataract for surgical intervention. Again, when we apply the rule of the risk factors to evaluate the risk factors in this patient for the developing the cataract and developing inflammation, we can say that the patient has got a lot of risk factors. The age is less than 7 years. The duration of uveitis is less than 4 years. She is ANA positive. These presented with oligoarticular GIA, where the patient was in a full systemic immunosuppressants with a full dose of topical and systemic corticosteroids. All of these are risk factors for the development of the cataract as well as the possibility of developing of post-operative inflammation. In these cases, I would suggest doing the cataract surgery without implantation. And here is the post-operative results with the best corrected visual acuity and a clear visual X over a period of follow-up of 1 year for the right eye and 6 months for the left eye. So my take-home messages is the decision of leaving a child aphakic versus implanting a lens is a complex one. the issue should be discussed thoroughly with the parents and with every individual case. The proper case selection, strict perioperative control of inflammation is a must. Identifying patients at high risk for developing postoperative inflammation and justifying the pros and cons of IOL implantation for every individual case is very important. Still, to the moment, there is no strong consensus about the IOL implantation in GI patients with uveitic cataract, and still we feel that we have got a literature gap to be full. Thank you.